mass to the point that you actually start compromising function. So I know you know, but conceptualize and tell me why. Tell me which one of these is true. When you start to actually have osteoporosis, you primarily are losing what? Spongy bone or compact bone? Disproportionately. Spongy bone. And who can remember why? Yeah, there's more surface area to get at it, right? Because the endosteum was wrapping all of the inner surfaces, right? So what tends to happen in your spongy bone is you start to lose the structural stability. It's basically like some termites got at the framework of your house, right? At the framework of your house, and it basically just makes it more likely to lose structural stability. So this is osteoporosis, and osteoporosis can get really dramatic. Now, what kinds of symptoms are typically associated with osteoporosis? Well, first thing is you tend to lose height, and you lose height because among other things, the bodies of your vertebrae, remember the chubby little body part, right? They're mostly spongy bone, and they have a lot of gravity pressure going on with them. And so you start to compress those, and it makes you shorter. And if you combine that in addition with weak musculature, you tend to get this humpbacked appearance, right, as you age. So that's associated with osteoporosis. The other thing is, we talked about this last time, why when you're 85 can you fall, just a minor fall, and break a hip, right? So you get really easily fractured bones because the internal framework isn't very strong of your bones. And then the other thing is you tend to lose teeth. But it's not tooth loss because of tooth decay or even because of gingivitis necessarily. It's because, what are those little pockets in your maxilla and your mandible called that hold onto your teeth? Alveoli, right? Alveolus is singular. So what happens in a person with a decent amount of bone mass is the alveolus is pretty deep and it holds on to the tooth. And then what happens as you start to lose your bone mass is it gets more shallow, right? And then you can lose perfectly healthy teeth because of osteoporosis. Does that make sense? And nothing may actually be wrong with your teeth at all. You're just losing your teeth because you've lost your bone mass. It's really interesting when you see like the lower jaw of someone who's really elderly. Their jaw is teeny tiny. It's like little bitty thin. It almost looks like a long bone. Whereas in a healthy person, a healthy, relatively young person is pretty thick, pretty wide. Okay, so who is more likely to be affected by loss of bone mass? Well, it has to do with your gender, it has to do with your age, it has to do with your activity patterns, it also has to do with your ethnicity or your genetic heritage, right? So everyone starts to lose bone mass around age 30, but that's not a sentence, it's just a predisposition. If, however, you are a super wiggly 30-year-old, are you going to immediately start losing your bone mass? No, it's basically we tend to get a little less active as we get older, but that's not, you don't have to, right? Most of us start losing bone mass between the ages of 30 and 40, and by the time you go past 30 and 40, women on average after age 30 lose 8% of their bone mass per decade. Men only lose 3% of their bone mass. Most of that in women is accounted for after menopause. Yeah? After you hit menopause, your estrogen over the course of maybe a year, maybe a few months, maybe a little bit more than a year will go from relatively high to relatively low. And then once you lose your estrogen, you don't have it to maintain your bone mass anymore. So postmenopausal women actually lose 1% of their bone mass per year because of the loss of estrogen, right? That means after menopause, about 10% per year is how much you lose, right? So what can you do about it? We'll talk about that in just a second. So why is women so dramatic? Remember I told you guys last time that women lose their estrogen relatively quickly and dramatically. Men still have a decent amount of testosterone into their 80s sometimes. It's not as high, but it's still pretty high. And then women, of course, have less bone mass to start with, right? Just because of differences, the sexual dimorphism that's true in humans, males tend to be bigger than females. So you had less to begin with, and then you lose it more quickly. Does that make sense? After menopause? Okay, so now what does your ethnicity or your genetic heritage have to do with it? It has nothing to do with skin color, although interestingly, it tends to fall along skin color lines. Based on your genetic heritage, here's the predisposition. There are exceptions to this, but the predisposition is that the people historically who have the least bone mass tend to be of Asian descent, okay? And then you have Caucasians, right? And then you have people of Western European and Hispanic descent, which is like both Native Americans, South Americans, because you know they're all like mixed up together, And then the people with the densest bone mass who are least likely to get osteoporosis are people of African descent. Okay? And what does it have to do with? Nothing to do with skin color. What it has to do with is your genetic predisposition to how much collagen and calcium you deposit into your bone mass. And that's the genetics for it. Does that make sense? So, the other thing is, what about your body size? Okay. Now, if I'm a woman, and I am, what happens is that, remember that how your bones respond to mechanical stress and gravity. They build, right? So if I am doing weight-bearing exercise, then I build bone mass. Now, let's say I'm a big person, whether I'm really tall and muscular or really heavy for another reason, walking around and carrying my big old self around is weight-bearing activity, right? So what happens is big women tend to maintain their bone mass more than small women, right? Small women have less, but they're also putting less stress on their bone, carrying their little bitty bird bodies around. Does that make sense? Okay? So go ahead. So Corey, you're screwed, is all I'm saying. Right?
Yeah, I did some research about this, and there was an article that came up about like seals, and seals will give birth to their young on the beach, and those seals, like the infant seals, will stay on the beach for like 2 years until they actually like start living in the water more because it fills up their bone mass.
Oh, interesting.
Yeah.
Yeah.
Because if they're in the water, there's like
you don't build much bone mass. So exercising we know is really good for your skeleton. However, swimming, phenomenal for everything else. Really good for your cardiovascular, respiratory system. Really good for your muscle mass. Doesn't do a damn thing to help with maintaining your bone mass because the water is supporting, right? You're not having much mechanical stress. So if you really want to be a strong swimmer, you also have to lift weights, right? That's what you have to do. That's interesting. Seals. Okay, so now the other part of little women more than large women, why they lose their bone mass faster, is that fat tissue, estrogen is derived from fat, okay? So if you're really thin, then you are postmenopausally going to have a really hard time maintaining even low levels of estrogen. So after you get into your 40s, you want to make sure that you have a little body fat, right? And also it makes you look a little younger, FYI, right? A little body fat under your tissues makes you look a little longer. I'm not saying be obese. I'm saying exceptionally thin will make you actually stop secreting estrogen at all, right? So very thin women may stop producing estrogen. Now you've probably run into this when you talk about gymnasts, right? Or people with anorexia, right? Have you ever heard that sometimes they'll completely stop menstruating, right? And this is the reason, right? You're basically forcing yourself into an artificial early menopause by doing that, by being exceptionally thin. And what happens in situations like that is if you stop producing, it'll be put off a little bit if you're an athlete because you'll contradict basically what you're doing with weight-bearing activity. But it's really, really bad for your skeletal mass. And have you ever seen what happens to the growth of gymnasts, right? You get so thin that you actually stop producing estrogen that it'll actually stunt your growth as well. But if you have a person, for instance, who's anorexic, you can have a 20-year-old with the bones of a 70-year-old. So when I first started teaching, my very first year of teaching when I was in Texas, I just got out of graduate school. I think I was 28. And I got my first faculty job. And one of my students, who became a friend later, she's 26, and she eventually revealed to me that anorexia was just rampant for her family. Nature, nurture, probably both, really. And so she had been diagnosed with anorexia and had been hospitalized before. So had her brother and her sister and her mother, like all of them had. And how this manifested, among other ways, was that her sister at 32 had already broken a freaking hip. They were all on medication except for the brother. They were all the women were on medication for osteoporosis. And her mom in her 50s was already in a walker. Like they had lost so much bone mass because of this anorexia that this was just dramatic what had happened to them. Now the brother, probably just because of more bone mass, had not been diagnosed with osteoporosis yet, but he had been diagnosed with anorexia. So, and I didn't know this until the conversation started because I actually went out to dinner with her and her sister and her mother at one point. And then it was the weirdest thing. We went to an expensive restaurant and they were all competing to see who could eat the least. I'm like, I just paid $25 for that meal. I'm eating yours too. Like, what are you doing? I don't even understand you people. I was like, that looks delicious. Okay. So what do you do to avoid osteoporosis? Have some good genetics. Whoops, you don't get control over that. Exercise to stress your bones. Use it or lose it. Walking is phenomenal for your spine and your hips. Swimming is great for everything else. Doesn't really help with this. And don't be the woman who's afraid of lifting weights. Women are always like, oh, I'm going to get so super buff. Nobody gets buff on accident. It like literally does not happen. You're like, ooh, I lifted a weight once and now I'm hot. No, it doesn't happen, right? Now I've got amazing cut arms. By the way, that's kind of sexy anyway, right? We like that, right? Good arms are good. So you need to do upper body work to maintain your bone mass. In addition, you probably know this, but I'm going to reiterate it. Lifting weights is a triple benefit. A, you burn calories when you do it. B, it maintains your bone mass. And C, it increases your metabolism if you've actually got more muscle mass, right? Increases it long term, not just when you're doing it. So it's really an incredibly effective way to like maintain your body mass. Okay, nutrition. Of course, you need the stuff that you need to make your bone. If you don't have adequate calcium, you know you're going to make withdrawals from your calcium bank. You need calcium, you need vitamin D, you need the cell division, vitamins, vitamin C, and you need protein in your diet. Otherwise, you'll start taking it out of your bone mass. If you're a smoker, you should stop. For some reason that we don't actually fully understand, smoking zaps antioxidants from your system, and it tends to cause you to decrease the amount of collagen that's in your bone mass. So I think it's because it zaps vitamin C, which you need for cell division and protein synthesis, but we really don't understand it yet. Now, treatment, hormone replacement therapy for postmenopausal women. That's something to be considered, but hormone replacement therapy for postmenopausal women also has a set of risks associated for a small pool of women. So this is why as you get older and you get more educated about your own health, you kind of take ownership of it, right? So what does the doctor know about your family history? Exactly what you tell them. That's what they know. So with hormone replacement therapy, if I were postmenopausal, I could go in and I could consider it, but I probably wouldn't want to do it if I had a family history of breast and ovarian cancer. Because there are certain forms of breast and ovarian cancer that will increase in propensity dramatically with hormone replacement therapy. But so you need to know that, and actually there are some tests that test for that specific form of breast and ovarian cancer. So I'm not saying it does it with everyone, otherwise they wouldn't use it as a treatment at all. But for a certain subset of women, it increases the likelihood of breast and ovarian cancer. Okay, what do you do? Calcitonin, you can take it, you have to inject it though. Fluoride actually helps a little bit. And then there are a couple of drugs, including one of them is Fosamax. I don't know if you guys have ever heard of Fosamax. Fosamax increases osteoblast activity and decreases osteoclast activity. So it not only can stop bone mass loss, but it can reverse it. But originally when it came out, it was still patented, and it was around $800 a month for Fosamax. So obviously a lot of elderly people are not incredibly wealthy. So if you didn't have amazing insurance, you couldn't get access to it. And now there are some off-label and some generic forms, but all of the newest medication for this is always outrageously expensive. It's usually like 4 pills a month. They're like $200 a piece, each pill, right? And you know why? It's because of Martin Shkreli, who my husband calls Pharmadouche. That's the dude that like had HIV medication and got the patent for it and immediately increased the price 700%. I'm like, oh my God, how do you sleep at night? Go ahead.
So when bodybuilders drink protein powder, does that increase their muscle mass?
It does if you are working out and you have, so I'll just try to do this quickly. It's kind of a quiz question. What happens is you build muscle mass because you make more contractile proteins in your muscles, yes? Mm-hmm. So if I try to lift something heavy over and over again and it's at the limit of my capacity, then what I'm telling my muscles is kind of the same thing that I'm telling my bones. I'm saying, I need you to be stronger in the future, right? And you'll make more contractile proteins if you have the resources to make them with. So that's why protein will help, but not if you're not working out, right? If you're not working out, it's just going to make you fat, right? So you got to work out. Okay, so Now, let's move on to articulations. And with articulations, we may not finish these. It's okay if we don't finish the disorders because I can just not ask you about them. But let's talk about articulations. Okay, so this is Chapter 9. Does that mean you're going to be tested over all of Chapter 9? No. You're going to be tested only over the stuff that is in your notes over Chapter 9. Chapter 9 is articulations, which is how joints are put together, but then it's also how they work. And the part of how they work I do with muscles, not with bones, right? Because it's actually muscles that move the joints. So let's talk about classification of joints just generally. And you know that articulation means joint. Here is a truth about articulations or joints. The more stable you are, the less mobile you are. And you're always sacrificing one thing for the other. So the most stable joints that you have are like the sutures, your cranial sutures, but it's still a joint, isn't it? Because it's two bones coming together, right? I know you don't think of it as a joint, but it is. It's just super stable. It's so stable that if I got smacked on the side of the head, it would not slice my brain in half, right? Okay? So that's the most stable joint. The other extreme is this one. Ow. I meant to do that. It's this one, right? Which is the most mobile joint that you have in your body, but it's also the one that's most likely to get dislocated, right? So you have to basically, it's a trade-off between stability and mobility. Okay, so let me introduce you to the categories of joints. Most stable to least stable is what we're going to do. Most stable type of joint, you probably wouldn't even think of it as a joint because it's not very wiggly. And they are called fibrous joints. Fibrous joints are, hold on, get in there. These are my favorite earrings. Okay, fibrous joints are bone, no cartilage, ligament, bone, bone, ligament, bone, right? Like this right here, the sagittal suture is bone, ligament, bone. It's just got these little bitty ligaments in between. And so it's really not supposed to be very wiggly. They're supposed to pretty much stay in the same orientation to one another. And you can make the sagittal suture even more stable by interweaving the little serrations, right? Does that make sense? So it's actually got little ligaments in between, but really no cartilage there. So it's the most stable joint that you have. It's called a suture. Two other types of fibrous joints are a gomphosis. Gomphosis has the periodontal ligaments just holding your teeth into your alveoli. Yeah? That's not supposed to be wiggly in an adult, is it? No, that shouldn't be wiggly. And then the other one, and this is the weirdest one. This is the most wiggly of the least wiggly type of joints. And that is called a syndesmosis. And what it does is it holds the radius and the ulna in the same about space away from one another. And it's really just a layer of dense, irregular connective tissue between them. So that the radius and the ulna, even if you spin them, they stay the same like space away from each other. So it's not really very wiggly compared to like a cartilaginous joint that we're going to do next. Okay, so the next type of joint that's a little bit more wiggly is called a cartilaginous joint. And a cartilaginous joint goes bone, cartilage, bone. Yeah, Cora?
Oh, can the syndesmosis also be called aponeurosis?
The aponeurosis is the name of that space between them.
Oh,
the syndesmosis is the joint itself.
Okay.
Yeah, it's the name of the fibrous tissue between them is an aponeurosis.
Okay.
Okay, so now let's meet the next type of wiggly joint, slightly more wiggly, and you can feel them here. If you put your hands just lateral to your sternum and wiggle, you can see that there's cartilage between these two bones, right? That makes sense? So you can feel it's got a little bit more movement there. So it is bone, cartilage, bone. This is a cartilaginous joint. There's two categories of cartilaginous joints. Is it hyaline cartilage or fibrocartilage? If it's hyaline cartilage, bone, hyaline cartilage, bone, it's called a synchondrosis. Plural is synchondroses. Good? Okay? And of course, the costal cartilages are examples of that. Interestingly, so is the epiphyseal plate, right? Isn't that bone, cartilage, bone? Bone, hyaline cartilage, bone? Okay, so that's actually considered a synchondrosis. And the other one is a symphysis. And you've met a symphysis before, right? Because this is the pubic symphysis. Bone, fibrocartilage bone. Yes? These are also considered symphyses, the intervertebral joints between your vertebrae. Okay, so these have a little bit more wiggle than a fibrous joint. And then the last, the wiggliest joint, is as far as we're going to get today. Okay, the wiggliest joint is called a synovial joint. So let me just explain this to you. Okay, a synovial joint is, listen, bone, hyaline cartilage, fluid-filled space, hyaline cartilage bone. Got it? That purple space in between will be filled with a thick viscous fluid called synovial fluid. Now these are super wiggly. What's the purpose of that fluid in there? Friction. Yeah, reduce friction. It actually supports some of the weight. That fluid is so viscous that you actually can have the bones being supported by the fluid and not actually touching one another. Like, have you ever hydroplaned in your car right after it rains? If there's viscous fluid on the road, it can actually support your entire weight of your car. So this is like motor oil. It's called synovial fluid in there, inside the synovial joint. So let's learn the structures inside a synovial joint. First, this right here is, of course, your articular cartilage. It's hyaline cartilage, yeah? The only thing special about the hyaline cartilage in a synovial joint is that it doesn't have perichondrium around it, because it doesn't need it. It actually gets its nutrients from the fluid, right? So it's got no perichondrium around it, okay? And every space inside the joint capsule that isn't actually coated with cartilage is coated with what we call the synovial membrane. And this is the membrane that actually makes the fluid. It makes the fluid and dumps it in there. It looks like an epithelial tissue, but it's not. Strangely enough, it's actually a connective tissue. Okay, so that will make the fluid and dump it in there. But then that alone doesn't hold the sides together very well. So in addition to that, what I have around the outside, this is the synovial membrane, right? And that's the inner layer of the joint capsule. And then around the outside, imagine I take a tube sock and I pull it all the way up over my knee. So what I have is the tube sock is continuous with the periosteum here, runs around the knee, and is continuous with the periosteum there. What it does is it actually weaves into the periosteum because the joint capsule is actually also, on the outside, made of dense, irregular connective tissue. Does that make sense? Okay? So that's actually what holds it together, so the entire capsule. This would be like the knee. Only, now let's add just a little bit more structural stability to it, okay? And a little bit more structural stability is not shown here, but you can have a ligament that attaches the two bones to one another within the joint cavity, right? You can have a little fat in the joint cavity for a little extra cushion, right? And then you can run a muscle with a tendon across the outside of the joint cavity to stabilize it. And so if you have strong muscles around a joint cavity, it actually helps to stabilize the joint, right? If you are a knee, you get two extra pieces in there, because as we developed bipedalism, put a lot of stress on our knees. What happened is we developed two extra pads of fibrocartilage in addition to what we're seeing here. We have one here and one here. They are called the lateral and medial menisci. Plural is meniscus, singular is meniscus, okay? And what they are is two fibrocartilage pads, lateral one, medial one, right? Have you ever known anybody who tore a meniscus, right? Lateral or medial meniscus. So it is in addition to the other synovial stuff. That make sense? Okay, so we're gonna stop there. Here's what I'm gonna do for you. Just so that you will have talked about these, what I'm going to do is do like a little 5-minute lecture and put it up for the arthritises, right? I don't even know if I'll ask about them, but it's a good thing for you to know. So I'll put a little 5-minute lecture up under the other lecture. It won't be up until later today though, okay? So don't worry too much about it, but I don't want you to not have learned anything about arthritis. And if you, go ahead. 50 minutes to take the test. I usually give you like 55, but as many as I can possibly get in a 50-minute. Right now it's sitting at 35 multiple choice, 15 fill in the blank, and then 10 clicker ones. So, no, we'll do it like 20 minutes in, and then you can do the other stuff while you're doing the clicker ones, right? So after you get your answer in, you can go back and do other stuff, right? I start it right like 20 minutes in so nobody misses it if they come late.